Welcome everyone. My name is Achit and I'll be your moderator for tonight's webinar. I am excited to welcome Dr. Erin Elliott as our speaker tonight for a discussion on airway analysis and the pivotal role intraoral scanning and cone beam computed tomography, CBCT in other words, play in the treatment process. Before we get started, I would like to take a moment to go over some housekeeping. If you have a question, please type it into the box labeled "Have a Question" on the left side of your screen, and we'll answer them live at the end. This webinar is sponsored by Dentsply Sirona. Henry Schein is not offering CE credit for viewing or attending this presentation live or on demand. Dr. Elliott, welcome, and thank you for being with us tonight. I will pass it over to you.
Thank you so much. I am honored to be here. It's a busy week of speaking as Dentsply Sirona World is coming up, but it's an awesome opportunity to really let the technology shine and how it's helping us in dentistry. Tonight is going to be a definite overview. 50 minutes is not enough time to truly give you A to Z of sleep apnea, but we are going to start with the overview of sleep apnea, how dentists should and could be involved, and then I do have some step-by-step of using the scans and the bite. So I am a dentist in Post Falls, Idaho, way up in the panhandle of Idaho, way up in the north, the skinny part. And we're in a very growing area, but you'll notice I've been a part of Post Falls Family Dental since 2003. And I created Sleep Better Northwest in 2009. And that really gave freedom to patients to come see me for the specialty and keep the dentist that they may love. A lot of times they end up loving us more. And I just got a digital sign, and I have to tell you, I'm having so much fun with it that we really get to show some of our character before coming in. We do have a large team. It's a busy general dental practice, and you don't necessarily need to have like a whole separate practice for this. I integrate it into my daily life of dentistry, and a lot of it is because I have a specific assistant dedicated to this. And some of you might not be there yet, but you know, it really helps to have someone that's in charge or owns the program. It can be very team driven. And I got to do this article for Dental Sleep Practice magazine, and it kind of started out as how I'm a nice person. I love the reps. I'm always willing to talk to them, unless they're trying to sell me on cone beam for sleep apnea. I chased them out the door because you don't need cone beam to treat sleep apnea. Like, it doesn't screen the patient and that sort of thing. Well, what I didn't realize once I had cone beam is how much it benefits my sleep patients. A lot of it is the conversation starter, connecting the dots, why dentists care about sleep and how we're so close to the airway. But a lot of it is so that I can see their nasal obstructions, we can see their sinuses and turbinates, and I'll share some of those findings and how it makes an impact in sleep. And I love that it has a picture of me taking the cone beam scan. It's actually my team that usually does. But with the cone beam, I was able to add implants, and definitely the ROI is there. And I definitely use it for sleep also. So I've just had so much fun as a clinician adding more to my menu, including this case. So if you want handouts from tonight, go to joinsleep101.com. You'll enter your email address, and I will send it out tonight to a link to a Dropbox folder, and you can have notes and some of the blow-ups of the graphics that I'm going to show. So we break down the sleep workflow into 4 steps: awareness, diagnosis, financials, and treatment. And so often the dentists get focused on the treatment. And there is a ton of dentists who have a ton of sleep education, but no patience to put it in because they forgot about all the other steps. You know, the treatment is the dentistry. That's kind of the easiest part. But creating awareness in the patients that you have, I get asked, what doctors do I get referrals from? You're not there yet. You need to get the workflow ironed out and dialed in. And you have so many patients within your own practice. And then making it easy for your patients to get to the diagnosis. That's the magical step of where you take the patient from, I don't think I really have a problem. My wife is just nagging me, to, oh my gosh, I better take care of this, to urgency. And then, of course, the dreaded medical insurance, we will talk about that. But just like if you were treating an Invisalign or clear aligner or Sure Smile case, you can do it fee for service, but you have to create a value to what you're providing. And the sleep study is the magical step for that. So obviously we like to see oxygen getting to the vital organs in the brain. And obstructive sleep apnea is when there's a physical blockage or obstruction of the airway, and it's usually the tongue and soft palate that cause the problem. So here's a sleep MRI, which basically shows the obstruction in real time. And most people don't realize how large the tongue really is. Of course, we do as dentists. But if you're prepping a crown on 15 and the tongue is in the way, they probably have sleep apnea. Or if you're a hygienist and you're scaling, the maxillary teeth and the tongue's pushing out of the way, probably has sleep apnea. But most people aren't aware because they're asleep. And I'm just going to share this specific case, and hopefully you can hear the narration. But it can be pretty scary. And again, most patients don't think they have a problem.
Wait a second, though. Wait a second. And there he goes. Stops breathing. Trying to. That's what. Trying to breathe, can't do it. Trying to breathe, can't do it. Nope, still no breathing. Trying to breathe. Trying to breathe. Oh, a little bit. There we go.
And if you notice, he lifts his head up and he brings his lower jaw forward to get oxygen. So it can create a bad cycle. So as we go to sleep and we relax, our airway narrows, you can have snoring or not have snoring. Women definitely present differently as insomnia. And the airway narrows to the point of collapse, our oxygen goes down and our body says, oh my gosh, we better breathe. So it shoots out adrenaline or cortisol, which is the stress hormone, to open up our airway. Breathing resumes, we relax, kind of happens over and over again all night long. And so there's varying degrees of sleep apnea. So you can see here that air is still getting through, but the airway is narrowed. What they call this is a hypopnea. Hypo means less than. So a hypopnea means less air. And then there's an apnea that is a complete obstruction. That means without air, apnea in Latin. So it's a complete blockage of the airway. So what a sleep test does is it'll add up all the times that your airway was partially closed and how many times your airway was completely closed. In addition to the airway being closed, the oxygen has to desaturate 3 or 4%. So the airway has to close down for quite a while for that oxygen to, let's say, go from 96 down to 93 or 92, and then they count it. So this is kind of my analogy, is that a hypopnea is a kink in the hose, and then apnea is where the airway is completely closed off, and snoring shows turbulence or vibration. So that gives us, in a sleep test, the AHI. And unfortunately, this is a very archaic scale, but this is what the medical world goes off of. They say anything less than 5 is normal. However, there's a lot of people suffering that don't qualify technically as sleep apnea because their body would rather wake them up than allow that airway to completely close. We call that upper airway resistance syndrome. And if you Google it, you'll see the symptoms include light sleeping, tossing and turning, not necessarily snoring, but just people that are exhausted and not necessarily sleepy. 5 to 14.9 is mild, and then 15 to 29.9 is moderate. Anything over 30 is considered severe. Even though I've treated people in the 30s and 40s AHI that respond well to Appliance. So we have to look deeper than just this number. What the insurance says is that anything that's mild to moderate, you can use an oral appliance first. You don't have to fail CPAP. In anything over 30, you have to show CPAP intolerance or a medical contraindication. Anything less than 5 is not covered. However, we still offer an appliance, the same treatment to people that are suffering. And then they also measure oxygen. An oxygen desaturation index is what ODI stands for. A lot of people don't report this. Instead, they look at nadir, which means lowest point. How low did that oxygen drop? And then how much time was spent under 90 is what I look at. So if we do conscious sedation here and monitor oxygen, and if the oxygen gets anywhere near 90, alarm bells go off, and I bring the jaw forward to get them breathing again. And that's exactly how an appliance works, just like CPR. And we want to see the oxygen above 90 most of the night. And I'll even tell patients, like, look here, your oxygen was below 90 for 40 minutes. And that's essentially alarm bells were going off. And we wouldn't be here if it wasn't common. They say 1 in 4 men and 1 in 10 women, but many more, I think, are just not caught. I think the numbers are even higher than that. But 50% of the age over 50, the incidence becomes equal in men and women of menopausal age. And that is because progesterone helps keep the airway open. And as the progesterone decreases in menopause is when our airway starts to collapse. And so all these symptoms of insomnia start to show up, and so many people chalk it up to, oh, that's just menopause, when really it's sleep disordered breathing or sleep apnea. And more studies, even Mayo Clinic did one, that shows that frequent insomnia is sleep apnea, 91%. The problem with this epidemic is that 80 to 90% of the people that do have it remain undiagnosed. And that's because the medical world still looks at it as an old fat man's disease. And I treat young, healthy looking, seemingly healthy people that sleep terrible. And it's anatomical. It's not just about weight. And so we need to be looking at the medical history, the symptoms, asking patients more questions, and looking at their anatomy. It's more prevalent than diabetes or asthma, yet we're not talking about it. And of those people that were tired enough to admit they had a problem, tired enough to go get a sleep test, and tired enough to go get the one and only treatment that was offered to them, how many are actually using a CPAP? And the numbers are about 60%. That's if they went and got it. So in creating awareness in your practice, the way you can identify patients is by looking at the medical history. Patients with hypertension, acid reflux, antidepressant or anti-anxiety meds, people whose REM sleep is always interrupted. That's where mood is stabilized. Patients that have cortisol getting pumped into their body while their body's supposed to be resting. Of course, they're going to be a little bit more anxious. Diabetes type 2. I just had a 40-year-old patient today, in shape. He's on metformin, and it's for diabetes type 2. And I said, how are your blood sugars in the morning? He goes, that's when they're the highest. I said, I'm going to make a bet with you right now that your blood sugars will start to regulate with treatment. And if so, you need to tell your doctor for me. That's what I get when I win the bet. So, and then just trouble losing weight. Ghrelin tells us when we're hungry, and leptin tells us when we're full. Those are regulated in deep sleep. And if your body never gets into deep sleep because your airway closes down, your body shoots out that adrenaline and it interrupts your deep sleep. Plus, when you're so dang tired after sleeping seemingly a whole night, you're not going to go work out, and your body tends to crave higher carbohydrate foods because it's a quick source of energy. Now, as far as the anatomical signs and symptoms, this is a pretty exhaustive list, and I have a blow up if you go to that joinsleep101.com. But if you just focus on a few, if you were to focus on bruxing and clenching, because that's the brain's way of subconsciously opening the airway, or acid erosion. Acid reflux is intimately involved with sleep apnea because as the patient, you saw in that video, patient's trying to breathe, and the airway's blocked, it creates like a vacuum effect of acid is pulled out of the stomach. And as the diaphragm works harder and harder to try to breathe, the acid is pushed out of the stomach as well. And we can see the erosion in the teeth. And a lot of patients deny it. But it's not just heartburn. People who clear their throat a lot or have like a non-productive cough or a sour taste in the morning or a hoarse voice in the morning, that's acid reflux as well. If you see the erosion in the teeth, bring up sleep, bring up the atypical symptoms. And then scalloped tongue, that basically tells us there's not enough room for the tongue, so it takes on the indentations of the teeth. And you see the scalloping when the patient first opens. When they stick out their tongue, a lot of that kind of goes away. So try to catch it when the patient opens. And then what does their airway look like? Do they have a small, narrow, floppy airway with a battered uvula, or is it wide open and like stiff? Like, does it collapse is the other thing I look at. This is kind of a cone beam just to orient yourself. I don't know if you can see my pointer or not, but in this top section, we're looking at a cross section. That's the spine and the mandible. In the black space there, the black circle is an airway at rest. And then on the right side, you can see the other view. And then in the middle, that's an apneic event. The airway is closed off. And then you can see what happens in a clench and how it braces open the airway. You can also see it, even if you don't have the volumizer or the airway software, you can still point this out to a patient. It's important to have a big enough field of view. You'll never regret going to a bigger field of view. And you can use this as a talking point. My hygienists do to say, hey, we're concerned. How do you sleep at night? You know, when I used to bring this up without cone beam, I would get like I had two heads. Why is my dentist talking to me about sleep? But using this certainly, like I said, helps connect those dots for patients, but also their eyes get big and like, oh, okay, maybe I should check this out. And the way that we do is with a sleep test. More and more, especially since COVID, home sleep tests are being utilized. And a lot of patients think they have to go spend the night somewhere strange with people looking at them, watching them, but home sleep tests are used more and more. And that would, in the hospital or in the lab, is called a PSG. HST or home sleep test. This is what the in-lab studies look like. So a lot of people are like, no way will I ever sleep with all these wires and channels. But just a reminder, dentists cannot diagnose, and each state is different on their rules as far as home sleep tests go, so make sure you check. New Jersey, Georgia, and Virginia are kind of hard and fast. And I'll certainly leave time for question and answer if you have a question about your state. But there's the traditional pathway that I followed for a long time was that I would refer to a sleep physician. Well, the problem was the patients didn't go. And if they did actually follow through, it was such a long uphill climb that patients would come back to me like a year later. So we refer out, there's a shortage of sleep healthcare professionals. So it takes a while to get in. Then they get a sleep test after that. And then they call here looking for the results. And really they're supposed to get them from the sleep lab, and it takes them a long time to call. And all they do is get a phone call and say, yep, you have it. Never once explaining to them what they actually have, to go pick up a CPAP that they never wanted in the first place. And they have to try it for 3 months. And then they turn it back in, and then they're kind of just left in the dark. And so hopefully we pray for oral appliance therapy referral after that. So that wasn't working real well. So what we did is we started utilizing telemedicine and owning our own unit. And we do get a diagnosis from a sleep physician. That's a hard and fast rule. My hard and fast rules: every patient that gets an appliance has had a sleep test. We have to know what we're dealing with. There are too many other types of sleep apnea, and there's too many patients that end up being super severe that need a CPAP, and you can't tell just by looking at someone. There's central sleep apnea, which absolutely needs a CPAP, and that's where the brain does not tell the body to breathe. And then there's obstructive sleep apnea, which we can treat with an appliance as long as they're not too severe. So we own our own, but we also utilize a telemedicine company that basically we refer there, they follow through, they build the insurance, medical insurance, they provide a prescription for the appliance, and it's kind of out of our hands. They chase the patient and make it very convenient for the patient to pay for it, as well as follow through with treatment. And again, that test is the magical step. All of a sudden, I'll say, you know that snoring? Well, actually, your airway closed down 68 times. Your sleep was interrupted this many times. Your airway closed down for 30 seconds. And here, look, every time your airway closed down, you turned over. That's why you're tossing and turning. Your heart rate is increased during these times. Like, it paints the whole picture for them and really creates value. So if you're not going to be billing medical, this is the value I'm talking about. And we're not providing just an appliance. We have to stop talking about the oral appliance as just an appliance. We refer to it as our cash fee is around $2,500, and we talk about the therapy we're providing, the program, and that includes the follow-up. So when we talk financials, we do bill medical. It can be frustrating. You just have to get started and almost have an attitude of like a competitive attitude, almost like we're not going to let medical insurance beat us. As long as you have documentation, you should get paid. Insurance, of course, likes to play the game of denying it, hoping you'll give up, and you just have to have that attitude of they will not win. So in medical world, you have to have a diagnosis code for every procedure you're doing. An oral appliance, E0486 is the code. It is considered durable medical equipment, which kind of puts us in a different category. And we also do bill out the consult and follow-ups. We do an initial consult and a sleep test, or we take scans at that appointment. We try to combine as many appointments as we can. And we can bill out for the initial consult and follow-ups. We do a delivery, a 1 to 2 week follow-up, depending on how many adjustments we made or how confused they seem, and then a 4-week follow-up. And then we kind of do a follow-up sleep test if they're in that moderate to severe category, make sure that the appliance is working, and put them on an annual recare after that, or see them in their dental appointment, regular periodic evaluations. But the only diagnosis code that works for an oral appliance is G47.33, and that is adult or pediatric obstructive sleep apnea. And here's the definition of the E0486. It's a custom oral appliance, and notice it does say includes fitting and adjustment, which, you know, the 90 days is in parentheses. We bill out every follow-up just to see what insurances cover it. Some make it inclusive. But this also means that the scans or impressions are inclusive as well. There is no separate code for that. I would not try to get creative. I had someone ask me today about creative codes they're using, and they actually get flagged and definitely not covered. So here's an example of what was paid for a claim. Every insurance is different on what their allowable is. But again, if you have the documentation, you should get paid. We try to stay out of network with everybody. So if the allowable is low, then we will bill out of network. If the allowable is reasonable, we'll get a gap exception, it's called, and bill in network. But we get to be in the driver's seat. Now, the other thing is, patients will look at the appliance, and when we tell them our cash fee is $2,500, they look at the appliance and they say, that costs $2,500? But how come patients don't do that with clear aligners? When we say a clear aligner case is $5,000, they don't look at the aligners and say, those cost $5,000. So I don't know why the consumer mindset is that way. And these same patients that are struggling to sleep will go buy a $8,000 mattress to sleep better, but yet don't see the value in what we're providing. So I think it's twofold. I think it's the way we talk about it. I think if we refer to the appliance costing $2,500, that sets a certain mindset for the patient. But we also present it as one big fee, due immediately. But we get very generous with our sleep. We basically will send out the scans when we have 500 down, and some people don't even owe $500 if we're going through their insurance. But if they're paying a cash fee, we take 500 down, and then I'll do payments for a long time after that. We use a merchant services company that was started by a dentist that basically we can keep track of payments like this. It does it automatically. We get 2 debit cards or credit cards that run at 12:01 a.m. on payday. So if the first one defaults, it goes to the second one. And again, it keeps track of everything for us and does it automatically. And so offering payments, in-house payments, and not having to go to a third party has made a huge difference in our case acceptance. And trying to not talk about it as an appliance versus a program or therapy. And then what I'm going to do in the next 20 minutes is essentially kind of go over the treatment and some more step-by-step. So treatment options, obviously losing weight, better quit smoking, no alcohol before bed. And then positional therapy, most people are worse on their back. And sleep hygiene is not just about clean sheets. I'm sure those help, but just good sleep habits. Going to bed early, to wake up early, getting 7.7 hours of sleep, creating a sleep routine that gets your body ready for sleep. Melatonin is actually a terrible sleep aid, but it's used so often. I mean, there's an entire aisle dedicated to melatonin because people are desperate for good sleep, when really oxygen and airway should be everyone's primary goal. Melatonin is a sleep initiator. It doesn't keep us asleep. Plus, it's a hormone that is naturally made within our own body. Taking an exogenous source that's not even FDA controlled can really mess up our melatonin production. In order to create melatonin, it is based off of light. So we want to have a really dark room and cold room. Our body temperature has to go down 2 or 3 degrees as melatonin is released. So I say a hot shower to a cold, dark room. Even the light from a TV or electronic can affect melatonin release. And that is my melatonin soapbox. There really is no magical pill for sleep apnea yet. There is some trials going on for a mix of 2 drugs. to try to help keep the airway open. But the big pharmacological treatment that we could use is something to keep the nose clear. So Flonase, nasal dilators, things like that to help promote nasal breathing is one option. It's not a good primary treatment, but it certainly reduces resistance and can help the appliance work better. Surgery, there's all types of surgery. Some are successful, some are not. You may have heard of Inspire. It's a huge thing right now, and they're marketing very heavily, which is a beautiful thing, because when they go in for a consult, because they're CPAP intolerant and they're looking for the easy button, they realize this surgery is pretty evasive and not invasive, and not everyone is a candidate. So the ENT that's doing those surgeries around here are just referring people to me. So their marketing dollars are helping me. CPAP, that's, a lot of people think that's the only option that's given to them. And, if that is the best solution for them, I will tell them that too. And that sleep study really helps show us why psychologically they should prepare for CPAP. Essentially, it's a reverse vacuum. It just blows air. It does not give the body oxygen. It's just blasting air to keep the airway open. And finally, oral appliance is why we're here. The problem is in the United States, it's, there's some research that shows about 60% of sleep apneics are candidates for an appliance. 60%. And we have 5% of the market share. Even as more and more dentists are entering this and providing appliances, there's that many more people getting CPAP. Like, sleep apnea is kind of winning, because as the average weight increases across America, the amount of sleep apneics increases, and it's just like this spiral that we can never catch up. And for some reason, the medical world, they're familiar with CPAP. They know insurance. They're so medical insurance driven. They know insurance will cover CPAP, and it's almost like they have a rubber stamp. So getting out and educating the medical world helps. Treating patients that go back and tell their doctors, and I'll even coach the patients. Please tell your doctor how successful and how much you love this, and you want other people to know that this is an option. So the way that appliances work, just a quick anatomy review. All the muscles of the tongue and throat attach to that lower mandible. By bringing the mandible forward, you're going to prevent the collapsing of the tongue, but you're also going to provide support to that hyoid bone, which is that free-floating horseshoe-shaped bone that muscles of the tongue are attached to, but also the throat muscles attached to. So you're going to be supporting the hyoid bone so it does not collapse. In addition, you will be tightening that pterygomandibular raphe, which posteriorly is connected to the superior pharyngeal constrictor muscle. Also, as you bring that forward, you're going to be tightening the middle pharyngeal constrictor muscle and the inferior. So you're basically opening up the airway from the top to the bottom. Now, I knew appliances worked, but I was able to be part of a drug-induced sleep endoscopy, which is something that patients have to undergo before they are allowed to get the Inspire. And so I went to one of these, and essentially the patient was put to sleep, and then the video camera was put down the airway to show the collapse and to show what happens when they bring the jaw forward. So I'm going to share that video with you now, because to me, it was so eye-opening. So here you go. You can see the collapsing of the airway. You can see the vibration of the uvula. Those are the lungs right there. And then when you bring the jaw forward, do you see how much more open that airway becomes? Not just anterior posteriorly, but because those constrictor muscles are circular, it opens up the airway volumetrically in all directions. And I'm going to go ahead and show that again. And, I entered that drug-induced sleep endoscopy as this lowly dentist, and you'll hear, I don't know if you'll be able to hear it very well, but he says, see how that opens up? And then me, being a little brat, was like, see how an appliance works? I just thought it was funny, but he was cool. I was cool. It was good. It's beautiful, magical. So when we take scans of the teeth, you will need full arch. And the most important part to get is in the embrasures, which a lot of scanners aren't good at getting, and the distals of the mandibular second molars. It's very important that the appliance, the lower appliance, not the upper, but the lower covers the distals of the mandibular second molars. And so we don't see any tooth movement. You really don't see tooth movement, but if you don't cover the mandibular of the, or posterior of the mandibular second molars, you will see 18, 19, 30, 31 kind of spread apart. If they have third molars and it's going to open up the patient too much vertically, then don't cover the thirds. But definitely if they have the second molars, plus a protrusive bite that has some vertical component to it, you need room for the appliance, at least 4 millimeters. So I use what's called a Somnomed and the Primescan, Som gauge, I mean. So the Primescan is amazing. I have used other scanners to try to do full arch. It takes forever, and it collects so much data if it's not cutting out the cheek and tongue. It's almost like it knows what's important, and so it cuts out everything else, and then you don't have it slowed down because it has too much data. If you are doing CAD/CAM, it does draw automatically sets the axis and draws the margin. But I do, with the surgeries I do need to get the palate. You don't for oral appliances unless you're doing an edentulous arch, but it's amazing how it scans edentulous. And the anterior is so much better. We don't even use the powder for metal. But we also have a scan only. And that's important to know because we needed something that was full-time for sleep and ortho to get full arch scans, but it didn't need to mill out crowns. And so I was looking at scanners that might be, you know, more reasonable in cost until I realized that this was coming out. And so now it's our workhorse in sleep, and it was very competitive in price. And I'm telling you, the Primescan is the only scanner I will use in my hands, or my assistant's hands. Technically, I'm not doing it. But look how it captured. This is my dental partner, my business partner, how it captured his metal, his thirds, his anterior veneers. And when those don't have a lot of character to them, it's hard for other scanners to stitch it together. The other thing I discovered is how difficult it was for other scanners to stitch together a bite. And this can happen in a matter of seconds. So that's a Som gauge. And I set his bite when I had a few minutes, and then I wasn't even here this day. And I used a little dollop of bite registration in the posterior, and all we had to do, like, we already got the green check. She's just scanning a little bit extra, but it gives us that protrusive bite on both sides. So when you get to the buccal bite, instead of scanning like with maximum intercuspation, you put the gauge in and you can scan the open vertical as well as protrusive bite. And then we just send that via Sirona Connect. So it kind of looks like this when you're done. Usually it's more edge to edge, but since he had such a deep bite and was class 2, I didn't protrude him very far. But you can see I have a perfect amount of vertical all throughout. I'm not going to get that phone call from the lab that says, you know, you need more vertical, and then they arbitrarily open it. Also, if you want to know how to do the bite using the Som gauge, the reason why I like Som gauge is because I can change the verticals. I can do 4 millimeters or I can do 8 millimeters. It's not very common to have to raise the vertical. Most of the time you minimize it. But in men with scalloped tongues, and we do something called a snore test, sometimes increased vertical really does help. And saying that, if you want to learn how to do the bite, because we were kind of pressed on time here, I have a YouTube video that I will include the link in the email you'll get from me if you go to joinsleep101.com. But if you were to just Google Erin Elliott and Som Gauge, you'll see a video that I created, and I will also put it in the Dropbox, joinsleep101.com. So there's a million devices to choose from, okay, over 100, and every appliance is the best if you talk to the company, of course. I do have some favorites. I am not someone that has to have the best of everything or brand name shoes or purse or clothes or anything like that. However, when it comes to my scanner and when it comes to the appliance, I do want what is best. And it's because of what it saves me in chairside time. That is everything. My time is everything. And so with Panthera, if I don't have to deal with breakages and a lot of follow-ups because of discomfort or whatever, or breakage especially, then I will invest at the beginning so I don't have to invest my time on the back end. So Panthera is made from a nylon similar to Kevlar. It's lightweight and bulletproof, but I hesitate to tell my patients here in Idaho that because I don't want them to test me on that claim of being bulletproof. So the DSAD is kind of the original nylon 3D printed appliance. You can see it's held forward by those straps, and you change those out to advance the appliance, and you can do it in millimeter increments. And this is now PDAC or Medicare approved, which might not mean much to you right now. But recently they came out with the X3, which is more of a dorsal fin type. And my sleep champion, or it's my assistant dedicated to sleep, found this to be very comfortable. And then kind of the way that you order it, so you'll scan and send via Sirona Connect, and then we do go online to do the prescription. And there's a million different ways to customize it. And then they design it, get it back to you almost like it's so fast, the turnaround. So here's kind of an example. I'm going to show you, there is the scan only way, but we actually were, prior to us having that Primescan Connect, we were doing it in chairside. I find that to be the easiest. We randomly picked a crown. It could be any tooth number, and we'd scan the full arch. When it came to the buccal bite, we would use the gauge and provide increased vertical, and then we get to that manufacture stage. And then we could go to Sirona Connect, and we could send, and we'd basically choose Panthera, enter the order data. I kind of screwed up here because I see Panthera's right at the top, and I go looking for it, but it's already right up there because that's what we did previous. And you will add return date. You just kind of go to whatever is the first date that it offers you. And then as far as instructions, I'll put DSAT or X3 in there. But that part doesn't really matter because you have to go online to order. So then we're going to add to cart. It'll upload, and then we click submit. And that's when it gets sent off immediately. And then we go online, and I'm going to show you how to do a new order. And then we'll talk about cone beam. Like I said, there is lots of customizing options. And I'll show you just a couple tips that I think are important. This is kind of, I'm just showing you an example of how we traditionally, if there's more retention that's needed, they do ask for composite buttons. I've only done it once. It works really nicely, but a lot of times patients have, you know, crown, like porcelain crowns, and I'm like, I don't want to try to add composite to that. So you do have the option. I just kind of go with optimal values. Unless someone's a clencher, I'll do just the anterior, so it creates almost like an NTI effect or an anterior deprogrammer type effect. And now when it comes to this part, I'm very much huge on this. It must be tooth contact. I do not want to see teeth shifting. And so we do tooth contact on every time. Here I choose the STL because we sent it via Connect, and that's kind of that. And then they do have, Panthera does have a special for Primescan users. You get a free Panthera Classic. That's that DSAT version. And you can see there that sleep@pantheradental.com is a great way to reach out to get in touch with a rep. So when it comes to the cone beam family, Axios is the way to go. I wouldn't bother with any other options, but this is what we use it for. We can look for the airway obstructions in the turbinates. You can get a big enough field of view to look at the joint. I actually don't have that. It's not diagnostic, and it's not used even as a screener. Just because you have a small airway doesn't mean that you're going to have sleep apnea. However, they're starting to show that there is correlation. But even if you have a big airway, it doesn't mean you have sleep apnea. Your airway could be very collapsible. My analogy is kind of like the straws. You know, McDonald's has a nice wide straw, but they're collapsible. Whereas the coffee stirrer straw is very narrow, but it's very sturdy. So that's why cone beam can't be used diagnostically. Here is an example of turbinates. We're looking at a cross section. These kind of gray areas right here in the nasal area are turbinates. Black is airflow. Black is where the oxygen gets through. And so even though the sinuses are clear, the nasal area is almost completely blocked because of those turbinates. And then here is a video to show a deviated septum. Again, those are turbinates that you're starting to see. Black is airway flow. And in this person's nose, I bet they don't breathe out of their left nostril at all. And the patients love it when I almost like tell them their story. I'm like, they're like, yeah, I can't breathe through there at all. This is looking straight on. You can see that left nares nostril is almost completely obstructed. That is an ENT referral, but it also helps me set proper expectations for the patient, meaning that they may still snore. They may, you know, not have complete resolution, that they may need that extra referral to the ENT. And I'll tell them, I'm like, hey, your deductible's met with this appliance. Let's get over there. The ENT referrals or surgeries for the nasal area are not as invasive as Inspire or the oral surgeries to move the maxillomandibular jaw forward, or even cutting the UPPP. That is almost wasteful. Like, it's 30% success rate, but clearing the nasal passages is an easier surgery to recover from and to do. So you can use the airway volumizer. It's a great talking point, and I'm going to show you how easy it is to do, so that you can do it even chair side with the patient sitting there. So you can see here, we're going to analyze, and essentially you need to find hard tissue. So I use the hard palate, and then that spine, and that's going to auto segment it. And then you can see I press OK there at the bottom, and it's going to volumize it. We can move it around. We can kind of go up and down. We can, there you go. You can see, you can play with it a little bit and show the patient the constriction in the airway. And this is with the appliance in, and then, or the gauge in and prior to. This is not a guarantee of success, but it is a great tool to show patients exactly how appliances work. And here is those field of use. So I'm going to kind of wrap up here. If you have any question about what field of view to get, at least get this view. I'm telling you, you will not regret it. And if you want to, you can go as far as getting the joint and all of that. I will say I'm not a TMJ expert, but there you go. Also, just a review, jointsleep101.com. You will get some videos as well as a link to a Dropbox and all of that. So with that, we'll look at some of these questions.
Thank you, Dr. Elliott. We do have a few questions from our attendees. So as soon as you're ready, we can begin with our Q&A. So as soon as we're ready, Doctor, this is our first question from David Levine. He wanted to know, is Panthera Medicare approved? He thought that it only had to be connected by metal, herbst, or tap only.
Yes, so traditionally that is true. And so we would go with herbst. I really dislike the tap, and so do patients. But recently, as in like 3 or 4 weeks, the DSAD, the Panthera DSAD, is Medicare approved. And a lot of private insurances follow that rule. And that's why we call it PDAC. So it's not just Medicare that follows that, but it is allowed now.
Thank you, Doctor. Our next question is from Sarah. She wanted to know, can you wear appliances and a CPAP?
That is a great point. So right now there's a big CPAP recall, and because the foam was breaking down and creating cancer and other lung issues. So there's a shortage of CPAPs, and as we know, there's a shortage of chips. So making the new CPAPs to catch up to the recall is slow going. And so what I do is when we find a severe patient that really does need CPAP, but they're in this long waiting period, I'll talk to them about an appliance. Something is better than nothing. And I'll tell them it's not going to be enough, but it'll at least get you started. Saying that, an appliance is never wasted because you can do combination or hybrid therapy. What that means is, like I said before, CPAP just blows enough air. It doesn't care if you can tolerate it or not. It's going to blast air until the soft tissue's moved out of the way. Well, if we move most of the soft tissue out of the way with the appliance, but it's just not quite enough to resolve the issue, then the CPAP doesn't have to work as hard. And the pressures will be lower, and the appliance or the CPAP is more tolerable.
Thank you, Doctor. We had a follow-up question from Sarah. She gave us a little bit more clarification. She's had patients ask about night guards and wearing a CPAP together, and she's not sure how to answer it. Does it close the airway even more?
No, so there is one study that was done with just a handful of, not a lot of patients, the N was small, that showed that a night guard can make the airway worse. That's not for every person. People can still grind their teeth with a CPAP. But before I make any night guard, like I rarely make night guards in my practice, because before I make a night guard, I test them and ask about their sleep. Before I make anything for clenchers or grinders, I'm going to test them. And more often than not, they have some sort of sleep disordered breathing. So if I was going to make it for a CPAP wearer, night guard, I would talk to them about making an oral appliance because it'll give them that extra benefit. Again, I don't think it'll make it worse if they're wearing CPAP because the CPAP will just blow harder if the airway becomes more constricted due to the night guard.
Thank you, Dr. Elliott. Our next question is from Anne. In cases where teeth shifting does occur, what is the mechanism that results in a posterior open bite?
Okay, so the teeth actually don't shift. The Panthera, if you use the tooth contact, it's better than a retainer as far as to retaining teeth where they're at. You won't see teeth shifting. What you do see is a potential for a bite change. And she's right, you do see a posterior open bite. You don't see people looking like a bulldog, and you won't miss a meal, but there's just a little change where the teeth don't come together as much as they used to. I have seen some more significant ones in which the patients only kind of hit anteriorly and they went to a CPAP and it resolved. What they say is that it's as the jaw is postured forward at night, the muscles relax and adapt to that position. And because there's no teeth in the way, it's almost like they found their newfound freedom. Like they're just, the muscles are, this is where I like to be. And so there's never usually pain when patients have a posterior open bite. Only in this one study, it happened 17% of the time there was a posterior open bite. Half of those were favorable, meaning they were class 2 anyways. And of the unfavorable ones, only 28.9% of patients even noticed. And so it's usually the dentists that freak out a little bit more. But they say it could be because you're recapturing the disc, that the lateral pterygoids are getting shortened as they're held forward at night, or that the muscles relax and adapt to that new position. And I happen to think it's that one because of how many patients are either relieved of pain or are in no pain at all. And when I tell them, let's move you to a CPAP, all of a sudden they're like, you know what, that open bite doesn't bother me that much. It just forces me to chew slower, and that's not a bad thing.
Thank you, doctor. Our next question is from Purnima, and she wanted to know, how do you do an appliance for edentulous patients?
So I usually want teeth on the lower. If they are fully edentulous on the lower, since I do offer implants, I can offer kind of a package deal for the surgery so that we get them a more stable lower denture and then move them forward. So what we do is we actually replace the upper denture with the appliance. I use a Somnomed appliance. Panthera, you need posterior teeth. So I use the Somnomed with a flex liner, and that's going to replace the upper denture. And they'll just have to take their denture out another time during the day to let the tissue breathe, because people have died from sleep apnea, but not a fungal infection. And then we make the lower over the lower teeth, or even sometimes with the partial in place. It's because if you make it over the upper denture, you'll get sore spots right in the canine eminence because of the pressure that's put there. So we go through making a wax rim. It's a whole thing for the bite, but it is possible.
Thank you, doctor. We just have 2 questions left. Second to last question is from Scott. He wanted to know, when you're treating non-dental patients of record, and he goes into a little bit of explanation, patients from another practice or patients who don't have a dental home, how do you make sure that you won't be held responsible for the appliance removing crowns or causing other dentition problems with doing a comp exam and FMX radiographs?
So I don't do a comp exam or FMX or take bite wings. I tell them I'm evaluating you as a medical, from my medical point of view. I'm not looking for cavities or anything like that. When I'm looking at your teeth, I'm deciding which appliance would be best for you. And as long as they don't have any major work, even if they have a couple single crowns they have to do, I'll still make the appliance. I have not been held liable. If you want, there's certain releases that my sleep friends have created. I have other sleep friends that do require bite wings, but I want to help people get oxygen and breathing. If they don't have a dental home, then a lot of times we do, offer them our home. If they are a patient of record somewhere else, I never try to poach them, because I do get referrals from dentists as well. So I make sure that they go back to their dentist. I've had the opportunity to educate the dentists around here enough that they don't freak out about if there's a bite change or if a crown comes off. That's in the informed consent. So it's never really been an issue. If a crown comes off, then we're happy about it because it was leaking anyways. If there's a fragile tooth we're concerned about, we relieve around it. And you can do that even in the notes to Panthera, and they'll keep it loose around that tooth.
Thank you, doctor. And our last question is from David. In many states, dentists can't dispense NHSD even if the sleep MD is reading and diagnosing. And even using a company that takes care of all the HST arrangements, it becomes an issue with many patients having insurance that need to be a participant. Nowadays, patients are using participating providers and are not out of network. How do you get around this obstacle and sort of this scenario?
We do a cash fee for a home sleep test that we dispense. Again, don't just call your state board of dentistry, ask for it in writing. An opinion is not law. So as far as I know, New Jersey and Georgia are the most stringent, and recently Virginia. And again, opinion's not law. But saying that, I haven't really had that many people not follow through with sleep. I use sleeptest.com because of the in-network and out-of-network. Somehow they're able to be in-network, and they're all licensed in all 50 states, the sleep physician, so that the diagnosis counts. If it's going to be too much out of pocket, then we do refer locally. By that time, though, patients are much more willing to go. Again, I make it easy for patients, but we're in a place where we're getting referral. Patients are more willing to move forward with treatment because they're usually seeking me out at this point. But if it's a patient from hygiene, we try to make it as easy as possible to show them that they have an issue. If you get them in for a consult, find their pain points, connect the dots. They're usually eager to get a test by that time. So if you have to refer them out, not the end of the world. I have some great sleep physicians that, they were trained, they're younger, so they were trained with appliances. And so, again, getting the patients to go was the trouble before. But that's such a rare case that sleeptest.com can't take care of them.
Thank you, Dr. Elliott, for answering everyone's questions, and thank you again for the great presentation this evening.
Yeah, please go to Join Sleep 101. I'd love to, you'll get an email from me. I'd love to hear from you, and I can certainly answer any more questions you may have. Thanks for hanging with me, guys, and it was an honor to be part of this. So thanks to Henry Schein.
Thank you, Doctor. For everyone, we did record tonight's webinar, and we'll email the recording out sometime next week. We would appreciate your feedback via our survey that'll pop up on your screen shortly. Thank you all for joining us. Thank you, Dr. Elliott, and we look forward to seeing you on our future webinar.